Okay, so let's talk about the upper limb bones. When we talk about the upper limb bones, we've already mentioned in the past the pectoral girdle, and it includes two bones. It includes the clavicle, which is right here, and the scapula. Oh, sorry. In the upper limb, we have 30 free bones. And we'll talk about all of them. So the upper limb has a total of 32 bones, the pectoral girdle, which includes two bones, and the other bones, which includes 30 additional bones. So the 30 additional bones will include a humerus, a radius, which is lateral, an ulna, which is medial. Remember, we always go back to anatomical position. So this model here is an anatomical position where you're facing forward and your palms are faced anteriorly. We'll talk about the details of all of these bones. Here we have our carpal bones, and we have to know exactly the names of them in this section. We have 8 carpal bones. We have 5 metacarpals. And we have 14 phalanges. So let's start with the pectoral girdle. We're going to talk about the clavicle and the scapula. When we look at the clavicle, we notice it's somewhat S-shaped, and we have two ends. The sternal end, which connects to the manubrium of the sternum, and this is considered medial. And then laterally, we have what's called the acromial end, and the acromial end articulates with the acromion of the scapula laterally. Posteriorly, there's a little tubercle called the conoid tubercle. And if we could actually hold a clavicle in our hand, the conoid tubercle would give us some reference of knowing if it's in a right or left clavicle, because the conoid tubercle is always inferior and posterior. Interesting fact about the clavicle is that it's the most frequently broken bone in the body. Here's an x-ray of the shoulder. Here's the clavicle, and it's actually been shattered into 3 pieces. So the connection between one bone and another is what we call a joint, an articulation. So the manubrium of the sternum articulates with the clavicle at what we call the sternoclavicular joint. So that would be right here. That's the medial joint. Laterally, the clavicle articulates with the acromion of the scapula, and that's called the acromioclavicular joint at this end. Next, let's look at the scapula. So I know I have a video posted on online resources. You should take the time to review this, please. It kind of flips the scapula upside down, gives you the 3-dimensional images. But let's review some of the details of the scapula. So first of all, we have to understand this is an anterior view. So what we're looking at it is the anterior view is the part of the scapula that's up against the body. And the posterior view would be what we could see from behind. So in general, the scapula is triangular, and it has a very important function for a lot of our shoulder muscles to be attached to. So let's talk about some of the important structures that we do have to know. So first of all, here's the acromion of the scapula. And this would be where the clavicle connects. And remember, this was called the acromioclavicular joint, or the AC joint, at this place here. AC. Ugh. And the acromion is actually an extension of the spine of the scapula. And another important fact is if you even palpate your own shoulder, it's the little bone that sticks up the highest. So it's the highest point of the shoulder is the acromion. The other structure that's very visible in this perspective is the coracoid process right here. This is the coracoid process. It's going to be a very important area for muscle attachment. The other thing I want you to note is the angle here is called the inferior angle. We have to identify what is medial and what is lateral in relation to the scapula. So this region here is medial, or it's facing the spinal column. And this area is lateral, so this section of the scapula is facing the arm or the humerus. Here is what we call the glenoid cavity. And the glenoid cavity is where the humeral head fits into where, remember, we discussed the ball and socket joint. Okay, so this angle of the scapula is considered the lateral angle or the axillary border, and this medial border is considered the vertebral border. Another important feature that we notice here is this fossa. So a fossa is kind of like a space in the bone, often where a muscle sits. So the nice thing about the scapula, a lot of the fossas are associated with the muscles that sit here. So the subscapular muscle, which is part of the rotator cuff, sits in the subscapular fossa. This little notch here is called a scapular notch. This is the superior angle of the scapula, and this is the superior border of the scapula. So this is a posterior view. So this is the view we would look at if we're looking at somebody's back. We're looking at a classmate from the back. This is the angle that you would look at. And if you palpated it or touched the scapula, you would feel this bony process called the spine of the scapula. So when you feel or you see the spine of the scapula, you know you're looking at the scapula from the back. And the spine of the scapula is connected to that acromion. Okay, so that's an important feature, that the spine of the scapula connects to the acromion, not the coracoid process. So in this angle, we have to identify what is medial and what is lateral. So we know that when we see the glenoid cavity, that's going to be lateral, because this is where the ball and socket of the shoulder joint is located. So if we know this is lateral, this is the medial portion of the scapula. We have additional fossa here in that posterior image. So this one up here is called the supraspinatus fossa, and the fossa down here is called the infraspinatus fossa. And the supraspinatus fossa is where the supraspinatus muscle sits, and the infraspinatus fossa is where the infraspinatus muscle sits. We'll learn shortly that those muscles are part of the rotator cuff muscles. In this perspective, we also see the scapular notch, superior angle of the scapula, and the superior border of the scapula. The other thing that we kind of see a little bit in this perspective is that coracoid process and a little bit of the glenoid cavity where the humerus sits. So next, let's look at the lateral view of the scapula. And here you can see that glenoid cavity very nicely outlined. And this gray little suction cup is actually called the labrum, and it allows the ball and socket joint to kind of be a little more supported inside that glenohumeral joint. On this one, you can see the perspective of the acromion being higher than the coracoid process. So let's look at the different perspectives of the scapula. So first of all, you could kind of play with this. We know this is the posterior portion of the scapula because you could see the spine of the scapula connected to the acromion. You can see the supraspinatus fossa, the infraspinatus fossa. So looking at this, and this is the glenoid cavity here. Okay. So already we know this is the medial scapula. This is the lateral. Okay. Here's a lateral image of the scapula here. Here's the glenoid cavity, where the humerus articulates with the scapula. This is the coracoid process, and this is the acromion here. And then on the third one here, it's the anterior image of the scapula. Here's the acromion. Here's the coracoid process. And this is the subscapular fossa. And here's part of the glenoid cavity. Okay? And looking at this, we already know that this area is going to be the lateral portion. This is the medial. Okay? So let's talk about some of the joints. Let's look at page 49 in your manual, those lower images. Here's our clavicle. This is the acromion. So again, this joint and this ligament is called the acromioclavicular joint. And the ligament would be called the acromioclavicular ligament. The joint between the glenoid cavity and the humerus, this is actually the humeral head, that is called the glenohumeral joint or the shoulder joint. We talked about the ball and socket joint in the past. Remember, it was a diarthritic joint. It was freely movable. And we talked about how this joint is the most movable joint in the body. So the shoulder joint is even more movable than the hip joint. And we call it a ball and socket joint because it's kind of like the ball, the humeral head inside that glenoid cavity. Because it's so movable, it's also the most unstable. Often dislocated, the most commonly way it dislocates is the head of the humerus dislocates inferiorly. So it goes down like this. Okay. So let's talk about the ligaments. Remember the definition of a ligament? It connects a bone to bone, and we have a lot of ligaments in the shoulder joint. And the nice thing about the shoulder, like a lot of our ligaments, we name the ligament based on what two bones they're connecting. So for example, this one here, between the clavicle and the acromion, this ligament is called the acromioclavicular ligament. The next ligament you could see between the coracoid process. I think anatomists called it coracoid because it kind of looks like a bird beak. So the ligament between the coracoid ligament and the acromion is called the coracoacromial ligament. The ligament between the humerus and the coracoid process is called the coracohumeral ligament. And then the ligament between the glenoid cavity and the humerus is called the glenohumeral ligaments. Okay. So as you notice, on top of this glenoid cavity, that's just kind of like a little indentation in the bone, there's this fibrocartilaginous rim called the labrum. And what it does is it deepens the groove of the glenoid cavity and almost adds like a little suction cup with the head of the humerus, which adds some stability. sometimes in injuries, in order for this glenohumeral joint, if this is going to dislocate inferiorly, often you cannot do that without tearing the labrium. So if you've ever read a diagnostic study and it says the inferior border of the labrum is damaged or dislocated, it would mean that this area here is torn. So other structures exist in the shoulder joint are what we call bursa. We kind of talked about bursas in the past. They're little bags of interstitial fluid, and they're areas located in areas of high mobility, and they actually act as shock absorbers. And they're kind of in between tendons and bones to prevent like wear and tear in those areas. But these bursas can become irritated and inflamed. You've heard of bursitis, right? Sometimes you could get a bursitis in your shoulder, sometimes a bursitis in the hip. So the nice thing about these bursas, thank you, Julie, is that we name them often underneath certain structures. So here, it's located underneath the acromion, so we call that one a subacromial bursa. They're the little blue areas here. There's a bursa underneath the deltoid muscle that's called the subdeltoid. There's a bursa underneath the coracoid process that's subcoracoid. And then one posterior behind the subscapular, and it's a subscapular bursa. So let's talk about some of the ligaments associated with the pectoral girdle. So first of all, we have the coracoclavicular between the coracoid process and the clavicle. There's a coracoacromial between the acromion and the coracoid process. And then there's another one called the coracohumeral between the humerus and the coracoid process. And there's always the ligaments around the glenohumeral joint, which connects the humerus to the glenoid cavity. So let's look at a frontal section, or like as if we could separate anterior and superior regions of the glenohumeral joint. So let's review some of the structures we've already talked about. So the acromioclavicular ligament is the ligament that connects the clavicle to the acromion of the scapula, and that's the acromioclavicular joint, and that's the acromioclavicular ligament. So underneath this acromion, there's a little blue bag called a subacromial bursa. You see that here? It's a bursa. What also travels in here, here's one of the rotator cuff muscles. This tendon actually travels underneath here, insertion. So we'll learn that the supraspinatus tendon right here is probably the most common of the rotator cuff to get injured and tear, because this whole process, the acromion, the bursa, almost acts like a little guillotine from excessive repetitive abduction movements can injure the supraspinatus tendon. So in this section, we could see a nice image of that ball and socket joint, the synovial joint. You could see the articulating cartilage, the synovial fluid that exists within the synovial cavity. We also could see the entire capsule, the articulating capsule with the synovial membrane, which secretes the synovial fluid, and then the outer membrane called the fibrous membrane. On the lip here, we could see a little bit of the glenoid labrium that we talked about. A little bit of the, here's part of the biceps brachii tendon, which is the muscle that flexes our elbow. So let's look at a different perspective, a lateral view of the shoulder joint. Again, we could see the acromion on top here, the acromioclavicular ligament. Underneath it, the subacromial bursa. You could see how the tendon of that supraspinatus travels right underneath all of that. This is a nice image of the labrium. And you could see a little bit of the ligaments that connect to this area. So let's look at the ligaments. There are a lot of ligaments in the shoulder joint, as you could see. But we have to focus in on some of the ones that we have to learn for our class. So let's look at this. We have to know the acromioclavicular ligament, which we talked about here, between the acromion and the clavicle. We also have to know this one between the coracoid process and the acromion, called the coracoclavicular ligament. Thanks for letting me know. Another one that we have to know would be, in general, these, let me see which other one, coracoacromial ligament. So coracoacromial, acromioclavicular, looking what we need to know for our class. And these are some of the ligaments that connect the coracoid process to the clavicle. Okay. So again, we reviewed the two joints. The joint between the clavicle and the acromion is the coracoclavicular ligament, and it has the acromioclavicular joint with the acromioclavicular ligament. We discussed the glenohumeral joint, which includes the humerus connecting to the glenoid cavity, and there are glenohumeral ligaments in that joint. So let's move on to the next bone, and that's the humerus. The humerus is the longest bone in the upper limb. It's going to articulate proximately. Remember, proximal is closer to the midline. It's going to articulate proximally with the scapula, and it's going to articulate distally with at the elbow joint with the radius laterally and the ulna medially, okay? It's important to get our perspective. When we're looking at this perspective, we could see this is an anterior view, okay? So how could we tell? We could see the subscapular fossa here. I can't draw it. We also could see here in the elbow joint. That's going to tell us we're facing anterior. So how could we tell here? Because we could see this knobby structure. Laterally is the capitulum. Medially is the trochleum. Okay, so when you see this, we know we're looking anteriorly. Posterior view, immediately you're going to see the spine of the scapula, and it is in the acromion is an extension of that. And in posteriorly, you're going to see this fossa, the olecranon fossa. We'll talk about this in a minute. Okay? So let's talk about the anatomical regions of the humerus. So first of all, this is an anterior view, right? This is a posterior view. That can be all. We first of all look down here. You can see the capitulum, which is the round lateral portion, and here's the trochlear. And it actually almost is a T. This kind of looks like a C, right? We know, first of all, the head of the humerus is medial because that has to face medial to articulate with the glenoid cavity. Let's go down from there. This region below the head is called the anatomical neck. We have to differentiate the anatomical neck from the surgical neck. This is the surgical neck right here. Okay. We call it a surgical neck because when that area fractures, it generally requires surgery to fix. If we move down this area, it's kind of an irregular surface on the bone, and that's called the deltoid tuberosity, because our deltoid muscle, it's kind of up here, inserts there, which we'll talk about in a little while. This is the shaft of the humerus. So looking at this image here, we know the head is medial, right? Because it's facing medial, and therefore this side is lateral. So knowing that, if we come to this area down here, there's another little extension here called the medial epicondyle. So it's kind of above the condyle, it's kind of a little knob above this. It's called medial epicondyle, and on the opposite, it would be the lateral epicondyle. These are going to be important to note and know where they're at, because they're going to correlate with the insertions of muscles that move our wrist. So on this end, we have the anterior little knob called the capitulum. And then this is kind of like a T knob, and that's called the trochlea. So knowing this is medial, right, and this is lateral, we also have to note that the capitulum is going to articulate with the radius. Because remember, in anatomical position, the antebrachium region, which is right here, the radius is lateral, and the ulna is medial. Remember the PU? So the capitulum is going to articulate with the radius, and the trochlea is going to articulate with the ulna. So let's look at the posterior view of the humerus. We can see the head in a better perspective here, the anatomical neck, and the surgical neck. One thing we bypassed were these tubercles. This little knob on top is called the greater tubercle. Below that is the lesser tubercle. And these are going to be really important when we're understanding and looking at tendon muscle origins. And see this space in between the two right here? That's called the intertubercular sulcus. Remember from the past, a sulcus is a groove. So this is the groove in between the two tubercles, and also an important site for origins of muscles. So on this end, which is the posterior image of this, we have the shaft, a little bit of that deltoid tuberosity, but let's look at the distal end here. So on the distal end in the posterior, you're going to see the olecranon fossa. So what a fossa means is like a space or like a hole. And if we could look at the humerus, it's kind of like a hole. So what and students teach me sometimes how they learn these structures. If we could look at a humerus, it's like a hole. Students call it the butt. So the butt's in the back. It's actually called an olecranon fossa. Okay. And on this perspective, we know the head is medial. So then this little extension is going to be the medial epicondyle, and the one on the outside is called the lateral epicondyle. Okay. So on the anterior view, we see the capitulum and the trochlea. And on the posterior view, we're going to see the olecranon fossa. So let's look at some interesting facts about the humerus. So we know the head is going to articulate within that glenoid cavity at the glenohumeral joint or the ball and socket joint, correct? We discussed the differences between the anatomical neck and the surgical neck. And the anatomical neck is also the site where we have that epiphyseal plate. Remember what that was, the epiphyseal plate? That was the portion of the long bone where or when the bone is still growing, is a point of growth lengthwise. We talked about the next area called the surgical neck. The surgical neck often is where, if a fracture occurs, that is where we would need surgery. And then in the future, we'll also talk about an axillary nerve. I'll just mention it because we'll talk about it later. So the axillary, I can't even write with this. Axillary. Nerve travels in the same area. So when a fracture occurs along the surgical neck of the humerus, often it damages the axillary nerve, and we'll talk about conditions associated with that. We discussed the greater tuberosity and the lesser tuberosity, the little groove in between called the intertubercular groove. On the distal end, we have the capitulum, which kind of looks like a C, you can imagine that, and also the trochlea, which is kind of a T. So we also have to know that the capitulum articulates with the radius, it's lateral, and the trochlea articulates with the ulna, which is medial. Posteriorly, the radial and coronoid fossa are located right here. These are going to be important areas where when we flex the elbow, this is areas where the radius and ulna connect in a bent elbow. So looking at our humerus again, we know that this is medial, right? Maybe if I tried a different color, I don't know why this is not writing well. So we know this is the medial epicondyle. And in between the medial epicondyle, if you could flex your elbow and you feel that little bone, that's the olecranon process. And just medially to that, when you extend your bone, you're going to feel like a little indentation there. So that's called what we call the funny bone, okay? Have you ever like banged your elbow accidentally and like you get a little electrical shock into these 3, 4, and 5 phalanges? Yes, oh, you just did it. So what that is in this area right here, the ulnar nerve travels very superficially. So that's why in this area, we could feel that, or if we accidentally bang this, it will cause that sensation. We're actually like pinching a nerve, and the nerve is called the ulnar nerve. This shows a dislocated humerus from the ulna. Here's the ulna bone, and it's actually shifted forward. All right, so as we move down distally down the arm, the next two bones we're going to look at is the radius and the ulna. So we know that the radius is lateral, correct? This is an anatomical position, and the ulna is medial. We can see here how the radius articulates with the capitulum, and the ulna articulates with the trochlea, okay? The other thing I also want you to notice, is notice how the radius is thinner at the elbow joint, and then it gets thicker at the distal region where it articulates with the carpal bones. It's the opposite with the ulna. The ulna is the thickest at the elbow joint, and it's really thin at the carpal area, although the radius is the only of the two that articulates with the carpal bones. If we look at a posterior view of this, you see this little knob posteriorly, and that's called the olecranon process. So if you bend your elbow, you see that little knob that sticks out, the olecranon of your ulna bone. So again, you can see how the ulna is very thick proximally and very thin distally, and the radius is the opposite. It's very thin proximally, and on the distal end, the radius is what articulates with the carpal bones. So let's look at each individual bone and understand the anatomical regions. We'll start with the ulna. So the ulna is longer than the radius, and we know the ulna is located medially in anatomical position. The landmark is that olecranon, which we could feel here, and we'll learn that a lot of the main posterior muscle, which is the triceps brachii, inserts into that olecranon. If we look at the anatomy of the ulna, we notice this little U. That's how we could identify. That's called the trochlear notch. Remember, we said the trochlear of the humerus articulates with the ulna, and this is where that little knob sits in this trochlear notch. This little anterior rim, anterior of the ulna, is called the coronoid process. There's a little knob here called the ulnar tuberosity. Right here is called the radial notch, and this is where the radial head articulates with the ulna. And actually, at that articulation is where we have that pivot joint, which allows us to supinate and pronate. On the distal end of the ulna, we have a little process called the styloid process. So if you palpate at the end right below the wrist, you're going to feel a little bony structure that sticks out, and that's called the styloid process. And this is important for ligament attachments. So let's look at the radius. The radius is shorter than the ulna. It's located lateral in anatomical position. At the elbow joint, the radius is small, and it's going to get thicker as it goes away. So some of the structures we have to know about the radius is the little top is called the head. Below that would be the neck. Then we have this little process that sticks out, and that's called the radial tuberosity. On the distal end, we have a radial styloid process, and you could also feel that if you palpate the end of your wrist. We'll talk about a Colles fracture. We have to know that a Colles fracture is a fracture in the distal part of the radius, often seen in people over 50, especially if you fall like on an outstretched arm, you could fracture the distal radius, and that's called a Colles fracture. Here's some images of that, where there's a fracture on the distal end of the radius, common in women over 50. Mainly women, but also in men. So let's talk about, I know. So let's talk about the elbow joint. So the elbow joint is composed of the ulna, the radius, and the humerus. Okay. So here you could see the trochlea fitting into that trochlear notch of the ulna. And here you could see the capitulum that fits nicely with the head of the radius. And remember, this was a hinge joint. It was a synovial joint. This is the radial tuberosity that articulates inside that notch of the radius, and that's what it gives us that pivot joint, which allows us to pronate and supinate. And here's that interosseous membrane in between the two joints. So the ulna, proximal head, a little more detail. This C is going to give it away, or a U, because it's the ulna bone. This is called the trochlear notch. And that's where the trochlea of the humerus articulates. Posteriorly, it's that bony process, and that's called the olecranon. This little anterior lip is called the coronoid process, which upon elbow flexion, it fits nicely in the coronoid fossa of the humerus. Here's the radial notch, where the radius articulates here, giving us access to that pivot joint, which allows us to pronate and supinate. The ulnar tuberosity is just this like area below that. So if we look at the distal end of the elbow, we're still in the elbow, but we're looking at the distal end right here. And we could see how the radius and ulna articulate on this end. You can see the styloid process here of the ulna. And the point of articulation with the carpal bones is only with the radius. And this is where the radius articulates with 3 of the 8 carpal bones. We'll look at that in a minute. So again, to review, here's our radius. Here's the ulna. And I don't know if you noticed, but the ulna does not articulate with the carpal bones. It's only the radius that articulates with the carpal bones. There's 8 carpal bones. And always this is considered 1, and this is considered 5. Remember, we always go to anatomical position. In an anatomical position, in this position, the palms are always facing anteriorly, okay? So in anatomical position, number 1 is lateral, number 5 is medial, okay? Do you see that? There's 5 metacarpal bones, and we'll learn about the phalanges. There's 14 phalanges, or fingers, okay? So this is where we have to learn the names of the carpal bones. There's a few mnemonics. There's one in your textbook. But we also have to know what row is proximal and what is distal. So proximal is the row closest to the center of the body, or the proximal row. 3 of these articulate directly with the radius. So the proximal row of the carpals includes the scaphoid right here, the lunate, and the triquetrum actually articulate with the radius, okay? The pisiform is also in the proximal row, but it does not articulate. And you could actually feel the pisiform if you palpate that medial border at the base of the carpal bones. You could feel the pisiform. The next layer up would be the distal carpal bones. And that's going to include the trapezium, which is this one, the trapezoid, the capitate is pretty large, and the third one is the hamate bone. Okay, so those are distal, and these are the ones that articulate with the metacarpals. So here's a mnemonic, and I think the mnemonic in this is from your book. Let's just memorize one. This one says, stop letting those people touch a cadaver hand. And they correlate with scaphoid, lunate, triquetrum, and paisaform in that proximal row. The scaphoid, lunate, triquetrum, then the paisaform will be outside of that. And then the other one would be the trapezium, is lateral, trapezoid, capitate, and hamate. Okay? So make sure you use a mnemonic, whatever you need to do. You have to memorize these for your lecture and your lab, and know what is proximal row and what is distal row. So we do have to know at the wrist joint, the radius is the bone that articulates with the carpals, and the radius articulates with 3 of the 4 proximal row. That includes the scaphoid, the lunate, right here, the triquetrum. Okay? Also, understanding this, we have to know that the radius is the bone that articulates with the carpal bones, not the ulna. Most fractures, or the most commonly fractured carpal bone, is the scaphoid. Why is that? If you notice here, this one articulates directly with the scaphoid. So if you fall on an outstretched arm like this, your radius goes directly and hits that scaphoid. So that's why that's the most commonly fractured bone. So have you heard of carpal tunnel? Carpal tunnel, the anatomy around the carpal tunnel. Good. We have this ligament anteriorly called the transverse carpal ligament. And it's kind of like a little band there that holds all the tendons and vessels and nerves that are going into the hand on the palmar surface. Sometimes from repetitive trauma, like any kind of manual work, and even just on the computer for hours, this region can become very inflamed. I also see it a lot in women that like are pregnant or just had a baby, often can set this off. So what happens is, because of this inflammatory process, we compress the median nerve. We'll learn about these nerves next time. And the median nerve, yeah, thanks for sharing that, Alyssa. Any kind of repetitive trauma. Yes, I do too, Julie. I do too. I'm starting to get carpal tunnel from just the computer use that we're all using. So the symptoms of this, because this carpal ligament tightened and inflamed, it puts pressure on this median nerve. You get a sensation of numbness, pain, tingling in 1, 2, 3, first 3 fingers. Yeah. And they also, with the carpal tunnel associated with the computer use, it was more with the with the mouse. They designed like special mice to a mouse to prevent that a little bit. But a simple test to identify if that is a positive sign is called the Phalen's test. So if you just put your wrist like this in this position and hold it there for like a minute or two, if you have a positive sign for carpal tunnel, the numbness and tingling will start to go over your fingers. Another test is called the Tinel sign, and that's simple. You just tap that ligament and it'll shoot that sensation into the first, second, and third phalanges. A simple thing you could do for carpal tunnel is just wear a brace. Those of you, or I've had it, it's kind of like a brace with a little bar here that keeps that area, carpal tunnel space open. Also, other than wearing a brace, stretching exercises, opening that up, helps. Rehabilitation, therapy, chiropractic, all of that is to reduce this. Sometimes a cortisone injection can also help reduce that inflammation. But the injection, along with all the other conservative treatments, is usually the best method. It's not just the injection and you go back to doing what you used to do, it's going to magically go away. And in extreme cases, you actually go in there and cut that, we call it a transverse carpal ligament release, in order to alleviate that. So let's talk about the metacarpals and the phalanges. So we know we have 5 metacarpals, right? The thumb is 1, the pinky is 5, the thumb is lateral, and the 5th phalange is medial. And we're looking at this in anatomical position where the palm is facing anteriorly or forward. We also know that we have 14 phalanges, okay? It's 14 bones. We name them based on location. So for example, this would be the proximal phalange. This is the middle phalange. This is called the distal phalange. We also name the joints in this manner. Notice that 2 through 5 phalanges are made up of 3 bones each, okay, the proximal, middle, and distal. But look at the thumb. The thumb we also call the pollex. It only has 2. It only has, hard to draw with this. It only has a proximal phalange and a distal phalange. All right, so let's review some of the fractures that we discussed. So the most common fracture in the whole body is a clavicular fracture. We talked about how the most common carpal bone to fracture is called the scaphoid fracture. The problem with the scaphoid fracture, sometimes we call it, it's occult. We don't detect it easily. But if you look inside this anatomical snuff box or that little indentation, kind of posterior of your thumb, in a scaphoid fracture, this area would swell and often will become ecchymotic or black and blue shortly after a fracture, after a fall. The third condition we talked about was a Colles fracture, which is a fracture of the distal radius. Okay? All right.